This lecture is entitled Obstetric Hemorrhage Part 1. We're going to discuss the causes or the primary causes of obstetric hemorrhage. This is Jennifer Thompson, and this lecture is for N686 obstetric anesthesia. For additional information about this topic, you can refer to Chestnut Chapter 38, and of course I have references at the end of these lectures. I've split this lecture up into two parts. One is being the primary causes of obstetric hemorrhage, and the second is in treatment. So the references are at the end of that second lecture. Obstetric hemorrhage is the most common cause of maternal mortality worldwide, and accounts for about 25% of maternal deaths, again, worldwide. In the United States, hemorrhage accounts for about 12.5% of pregnancy-related deaths. And while it's been recognized for a long time that maternal hemorrhage is a major problem, interestingly, hemorrhage rates are actually continuing to increase in the United States and among other high-resource countries. And this is primarily due to increases in postpartum hemorrhage rather than just antepartum hemorrhage. While we don't really know what the reason for that is, it is, of course, important that we research what the causes are so that we can best manage it. Historically, we used to consider maternal hemorrhage or a large amount of blood loss to be greater than 500 for a vaginal delivery and greater than 1,000 for a C-section. But ACOG, the American College of Obstetrics and Gynecology, recently updated their definition of maternal hemorrhage. And now it is a cumulative blood loss greater than or equal to 1 liter or any amount of blood loss with signs and symptoms of hypovolemia within 24 hours of delivery. So what does that mean to you? Well, honestly, any EBL greater than 500 in a vaginal delivery should be closely evaluated. And obviously, cesarean sections who approach that 1 liter mark or even beyond that 500 liter mark, milliliter mark, we should be watching very closely and really looking for signs and symptoms of hypovolemia. There's a lot of speculation about the reasons for the continued increases in maternal morbidity and mortality due to hemorrhage is not only just because of some placental pathophysiology, but also because of the inability to recognize hypovolemia at an early stage. So when we think about the types of obstetric hemorrhage, we break it into antepartum and postpartum hemorrhage. And while there's kind of a little bit of crossover in some of this, it's kind of a nice way to categorize the types of hemorrhage. When we're talking about antepartum hemorrhage, we're primarily looking at the causes being placenta previa, placental abruption, uterine rupture, and vasa previa. And we're going to talk about all 4 of those. And then in terms of postpartum hemorrhage, we're mostly concerned about uterine atony, which is the #1 reason for obstetric hemorrhage, uterine atony. But additionally, other reasons for postpartum hemorrhage are retained placenta, placenta accreta, uterine inversion, and as well as genital trauma. Now you can see that placenta previa, uterine rupture, and placenta previa are all asterisks, and that's because those are all associated with cesarean section. So patient has a uterine rupture, a total placental previa, or a placenta accreta, they are going to go to C-section. Now, some of these other reasons or presentations could also be an indication for C-section, but those asterisk ones are guaranteed C-section. So another way to think about the etiology or to classify the etiology of obstetric hemorrhage is we often talk about the 4 T's of obstetric hemorrhage, and we can categorize most of the reasons for OB hemorrhage into either being an issue with tone, and that's uterine tone like atony, trauma, some kind of laceration or rupture, tissue or retained products of conception, and thrombin, which of course stands for any kind of coagulation dysfunction, either coagulopathies or even therapeutic anticoagulation. So before we get into discussing those specific etiologies, I want to first introduce something called TOLAC and VBAC to you. And TOLAC is a mnemonic for something called trial of labor after C-section, which means just what it says, as well as VBAC being vaginal birth after cesarean section. So oftentimes when patients who have a previous C-section decide that they would like to attempt a vaginal delivery, they may be brought in for a TOLAC, and that's a trial of labor after cesarean section to see if the baby, as well as mom, can tolerate labor after a C-section and actually have a vaginal birth. Some of the advantages are that, of course, these women avoid a major abdominal surgery, being a C-section. When we compare VBAC patients to repeat cesarean sections, these patients have a decreased incidence of postpartum transfusion, so the need for postpartum transfusion. They have a decreased incidence of bowel and bladder injury, as well as abnormalities in placentation, so accreta and previa. The VBAC success rate is somewhere between 60 and 80%, so it is pretty darn successful when candidates are chosen appropriately. So optimal candidates include patients who have had only one previous C-section, and actually, if they've had a previous vaginal delivery either before or before that C-section, then that increases their success rates. Additionally, they need to have had a lower uterine segment incision for their C-section. If they had that classic uterine incision, so that up and down uterine incision, then that's a contraindication to allowing someone to have a vaginal birth after C-section, as well as the patients obviously need to have a clinically adequate pelvis. What are the disadvantages? Well, patients who have had a previous C-section that decide for a TOLAC actually have triple the risk of uterine rupture. Additionally, there is a higher incidence of uterine wound dehiscence either during labor or after delivery. We see a much lower success rate in patients who have a history of having a baby with shoulder dystocia, and patients who have to have their labor induced with Pitocin or augmented with uterotonics, as well as the obese parturient, so much lower success rates. So the obstetric management of a TOLAC or a VBAC patient, obviously they have to have IV access because they are at higher risk for uterine rupture. Continuous fetal heart rate monitoring as well as intrauterine pressure monitoring is required. Oxytocin can be used as long as we're using it carefully, but there is a contraindication to utilizing prostaglandin gel, so Cytotec induction is contraindicated because there is an increase of uterine rupture associated with Cytotec inductions. It's been shown that patients are more likely to be successful with the VBAC if they went into spontaneous labor versus coming in for an induction. It's also important that all the resources are available for a C-section in case that patient needs to proceed to a C-section. So considering those obstetric management topics, let's look at anesthetic considerations for TOLAC or VBAC. Well, it's encouraged to place a continuous labor epidural in these patients early because of the higher risk for needing to possibly go to C-section. So we like to place epidurals early. And then we used to always be of the school of thought that if the patient all of a sudden had substantial or had experienced breakthrough pain, that would be a good indication of uterine rupture. But once we've placed that continuous labor epidural, it kind of blurs the lines a little bit. And so just pain alone is not a really good indicator of uterine rupture. It actually has a pretty low sensitivity and specificity. However, you have a patient who's been comfortable with the continuous labor epidural, all of a sudden experiences pretty substantial or severe breakthrough pain, then that's a relatively accurate sign of uterine rupture. So just pain alone is one thing, but having substantial breakthrough pain when they had been very, very comfortable, you get called to an OR suite for something like that, you probably want to be thinking uterine rupture. Fetal heart rate abnormality is the most common presenting sign of uterine rupture, even more common than just pain. So that's a little bit about TOLAC and VBAC patients. Again, they are at higher risk for obstetric hemorrhage. So let's move into antepartum hemorrhage and talk about uterine rupture. Uterine rupture, probably one of the scarier things that can happen in the antepartum period. The signs and symptoms of uterine rupture are an onset of non-reassuring fetal heart rate tones, uterine or abdominal pain, and a loss of station of the presenting part. What does that mean? Well, if the head was engaged down in the pelvis, and if, again, the head was the presenting part and the head was nicely engaged in the pelvis, and then all of a sudden there was a regression of station, so that head went up a little higher, that could be an indication of uterine rupture. And then, of course, vaginal bleeding as well as hypovolemia would be signs of uterine rupture. What are the risk factors? Well, of course, having a previous C-section or prior uterine surgery. I talked about how an induction of labor or utilizing a high oxytocin dose is a higher gives us a higher incidence or a less success rate with the ability to have a VBAC. But in patients who aren't even VBAC or TOLACs, patients who are having an induced labor with a high dose of oxytocin, as well as, or in addition to a prostaglandin induction, are at higher risk for uterine rupture. Patients who have had multiple babies are at higher risk for uterine rupture, so greater than 5, as well as patients who have a morbidly adherent placenta. So we'll talk about morbidly adherent placentas in just a bit. Other risk factors is a congenital uterine abnormality, something like a bicornuate uterus. So it is an abnormally shaped uterus, puts patients at higher risk for uterine rupture, as well as patients who have specific connective tissue disorders, something like Ehlers-Danlos could put them at higher risk. Patients who require use of forceps for their delivery, as well as needing excessive fundal pressure while they're pushing, or patients who have to undergo an internal pedalic rotation to rotate that baby around into place are at higher risk for uterine rupture, as well as patients who have experienced some kind of trauma, any kind of blunt or penetrating trauma, perhaps from a motor vehicle accident or some other kind of accident, are obviously at higher risk for uterine rupture. So how's uterine rupture treated? Well, an emergency delivery. You're going straight to the OR. Usually general anesthesia is necessitated. There is the occasional times when the uterus can partially dehiss and it not be a total rupture, and maybe at that point you would have time to place a spinal or dose an epidural, but generally speaking, a uterine rupture is going to require general anesthesia because it's an emergent situation. Once the baby is delivered, the uterus can be repaired if it is repairable, or they may need to do just a total hysterectomy. And I think that it's important for you to not underestimate what doing a hysterectomy on a parturient is, not only the emotional aspect of it, but more importantly, I guess I shouldn't say more importantly, but additionally, hysterectomies on a parturient have a far greater risk of massive blood loss than in a non-pregnant hysterectomy. So this isn't just your run-of-the-mill hysterectomy. And then obviously, the next step in treatment, or while this is going on, you're going to be volume resuscitating the mother and giving blood products as needed. Another reason for antepartum hemorrhage is placenta previa. A placenta previa is an abnormal implantation of the placenta over or close to the cervical os. You probably remember this from nursing school. The classic clinical sign is painless preterm vaginal bleeding, and that's what differentiates it from placental abruption, which we'll talk about in a bit. It is diagnosed by ultrasound, sometimes can be diagnosed fairly early in pregnancy. When it's diagnosed early in pregnancy, it's monitored closely throughout the pregnancy, and sometimes it resolves itself as the uterus grows, as the uterus grows in size and all of its contents, of course, grow in size. Sometimes the placenta moves a little bit away from the cervical os, so sometimes can fix itself, if you will. Preterm labor is a common complications of placenta previa, and so oftentimes patients with placenta previa will be on tocolytic therapy or steroids for the baby. You can see these pictures here, the difference between a normal placentation, which is usually up at that top or the upper side of the uterus, and then you can see a marginal, which is the placenta within 2 centimeters of the cervical os, a partial, which is covering part of the cervix, and a complete, which completely obstructs the cervix. So like I said, these patients are at risk for going to, these patients, some of the risk factors that go along with placenta previa is a previous C-section. If these patients have had any kind of uterine insult or previous placenta previa, any kind of damage or insult to the uterus can cause the placenta to implant onto the wrong area of the uterus. Multiparity is also a risk factor, as well as advanced maternal age and smoking. How does placenta previa treated? Well, if the patient presents with a partial or complete placenta previa, they need to be delivered via C-section. If the patient's unstable, that's emergent, but oftentimes it's known, and so they may bring the patient in before 40 weeks gestation for a C-section. A marginal previa, meaning if there's greater than 1 centimeter of space between the placenta and the cervical os, a trial of labor can be attempted and vaginal delivery is possible, but it's important to be ready for going to C-section. IV access, obviously good IV access, type and cross match for these patients is going to be really important. Regional anesthesia is fine for either C-section or vaginal delivery as long as the patient's stable. And it's important to recognize that there may be substantial postpartum bleeding. And that's primarily because when the placenta embeds the lower uterine segment and tears off of there, that portion of the uterus tends to not constrict as well as the rest of it. So there's some lower uterine segment inability to contract well. And while coagulopathy is was more common with some of these other morbid conditions, it is not that common with placenta previa. Moving on to placental abruption. Placental abruption can be classified as either a revealed or concealed abruption. And what that means is either there's bleeding from the cervix, and so that's a revealed placental abruption, or it can be concealed, meaning that the placenta has torn away from the wall of the uterus, but it kind of just is concealed as a little bit of a hematoma underneath the placenta, and so there isn't vaginal bleeding, and it's not as easily recognized. But the triad of symptoms that kind of coincide with placental abruption is vaginal bleeding, uterine tenderness, I really would call that uterine pain, as well as increased uterine activity. And that's how we differentiate a placental abruption to a placental previa, is previa is not associated with pain, but an abruption will be. We see a high incidence of placental abruption in patients who use cocaine and alcohol. Matter of fact, that is a major risk factor for a placental abruption, and it is associated with all of the hypertensive issues in pregnancy. So preeclampsia, gestational hypertension, all of these are associated with a higher incidence of placental abruption. It can happen preterm or intrapartum. It is the leading cause of DIC and parturience. Matter of fact, 1/3 of coagulopathies in pregnancy are due to a placental abruption. It can result in fetal hypoxia as well as prematurity. That placenta, as it detaches, it results in a decrease in transplacental oxygen. And so and sometimes you can see a decrease in transplacental oxygen even before there are obvious signs. And these patients are 5 times more likely to deliver preterm. What are some of the risk factors and associated conditions? Well, like I said, preeclampsia or hypertension, advanced maternal age, premature rupture of membranes, chorioamnionitis, acute or chronic respiratory illness, and then, of course, maternal substance abuse, primarily cocaine use, tobacco use as well. And studies have actually shown that parturients are at higher risk for placental abruption if the father or significant other, or father of the baby, I should say, is a tobacco user. And trauma can also lead to placental abruption. How do we treat it? Well, obviously, we need to consider the severity and urgency of it. So if we have a very severe and urgent case of placental abruption, we need to quickly get adequate IV access and make sure we have blood available. If the fetal heart rate is okay and mom is hemodynamically stable, then we can probably place a labor epidural and a vaginal delivery is okay. I can tell you that clinically, I've never really seen this come to fruition. Generally, when someone comes in with a placenta accreta, when it's known, then we're generally going to C-section. It may not be emergent, but it's usually pretty urgent. So if the fetus is at risk, so fetal heart tones aren't looking good, or there's any level of hemodynamic instability, we're going to C-section. If it's emergent, it needs to be general anesthesia. If we can get her there and she's looking pretty stable, we have time to place a spinal. So in the case of general anesthesia, you need to be aware of your induction drug selection. So, is the mom hemodynamically compromised? Maybe etomidate. Etomidate is a better option. Ketamine could be a little dangerous in these patients because it can increase uterine tone. So if you have someone who has a super hypertonic uterus and you give them ketamine, that may be a little bit of a concern. Obviously, aggressive volume resuscitation and blood, if needed, is going to be important. There's also a condition called cuvullare uterus, and that's where the uterus can't constrict back into pre-pregnancy or prepartum, I should say, state, because there's a bunch of blood that's infiltrated into the myometrium. We call that, again, a cuvullare uterus. So it's just the inability of the uterus to contract back into size after the fetus is delivered. Vasa previa is another condition that puts patients at risk for antepartum hemorrhage. And this is where the fetal blood vessels that are unprotected by umbilical cord or placental tissues cross or are near the opening of the cervix. As you can imagine, there would be high risk for trauma during a vaginal delivery, as well as a potential for exsanguination of the fetus. This is a condition where the mother is actually not at risk because the placenta, because of that placental, how the placenta isolates fetal and maternal circulation, but the fetus is at high risk for exsanguination. The presentation of vasa previa usually includes rupture of membranes, as well as painless vaginal bleeding, fetal bradycardia, and sadly fetal death. This is a true obstetric emergency that requires neonatal resuscitation, and they need to be resuscitated with colloids, balanced salt solutions, and blood as soon as you can get it to them. A prenatal diagnosis of this is key to neonatal survival. There's a pretty high preterm labor risk. So a lot of these patients that have known vasa previa are going to be on steroids, tocolytics. They're going to be admitted to the hospital early for observation. When they get to about 34, 35 weeks, there becomes this kind of risk versus benefits scenario where what are the risks of allowing mom to continue gestation, or is it better just to go ahead and take this baby via C-section now? So usually obviously these women are always taken to cesarean section, but oftentimes they're taken a little bit early to C-section. They're not allowed to go into labor. So those are the primary reasons for antepartum hemorrhage. Now let's talk about postpartum hemorrhage. I said before, the number one reason for obstetric hemorrhage is uterine atony. And uterine atony is it's a postpartum condition that can be caused by anything that overdistends the uterus. So things like polyhydramnios, multiple gestation, large baby, grand multiparity. So what kind of things really stress the uterus? Additionally, prolonged labor, induced or augmented labor. So someone who's came in for an induction and required high doses of something like oxytocin to augment their labor. Patients who have a cesarean section are at higher risk for uterine atony postpartum than vaginal delivery, patients with chorioamnionitis, and then patients who have previously been on any kind of tocolytic drug. So if they've been on mag sulfate, beta agonists, that also puts them at higher risk for postpartum uterine atony. Women of advanced maternal age, as well as parturients with hypertensive diseases and diabetics, all at high risk for uterine atony. Why is uterine atony such a problem? Well, if you remember during pathophysiology of pregnancy lecture, it was discussed about spiral arteries and how there is a remodeling of the spiral arteries, which are the arteries that penetrate the myometrium, or that muscular layer of the uterus. And those spiral arteries have to remodel in order to allow for arteriovenous anastomosis when the placenta embeds into the wall, to allow for uteroplacental circulation. So these spiral arteries are like maximally dilated. After the fetus is delivered and the placenta tears itself off from the uterine wall, the uterus needs to start contracting, and that thick muscular myometrium of the uterus needs to contract in order to contract those dilated spiral muscles down. If the uterus is not able to contract and squeeze those vessels, as you can imagine, that can result in substantial hemorrhage. So first, how do we prevent uterine atony? Well, prevention should be focused on active management of the third stage of labor, and that includes the routine administration of oxytocin after the baby is delivered, if it's not already on during delivery, and as well as uterine massage. And there's external uterine massage, which I know you all remember from nursing school, as well as something called bimanual uterine compression massage, and that is with the obstetrician or nurse midwife utilizes a hand inside, pressing right up against the uterus, where they externally use their hand to massage and really firmly push that uterus into shape. So after strong attempts at prevention, which should always be utilized, treatment is after oxytocin is being administered, finding appropriate second-line uterotonic drugs, and we'll talk about some of those, as well as fluid resuscitation and monitoring closely. If the patient is under general anesthesia, you want to halt any volatile anesthetic agents, because that, of course, can cause uterine atony, relaxes that uterus. Let's talk about the uterotonics. Oxytocin is our first-line agent, and like I said, it is just given to everyone in that third stage of labor. It's part of the active management and prevention of uterine atony. We usually give somewhere between 10 and 40 units per about a liter of fluid. It can also be given 10 units intramuscular. There are really no contraindications to giving someone oxytocin, but there are side effects. And the side effects are a decreased blood pressure due to vasodilation. So in response to that, we see an increase in heart rate. It can also actually cause some arrhythmias. In patients who are susceptible, it could cause a myocardial infarction, as well as has antidiuretic effects that can lead to water intoxication. And it's important to recognize that it does have a short duration of effect. So if the oxytocin is turned off for even a short period of time, the effects are gone very quickly. Methergin. Methergin is a second-line drug. It causes intense and prolonged uterine contractions. It is an ergoalkaloid, and it has some pretty substantial vasoconstrictive actions. We give it intramuscular, 0.2 milligrams is the dose, and we have to be very, very careful in patients who are hypertensive or who have preeclampsia or coronary artery disease, as these are relative contraindications for administering Methergin. It can cause severe hypertension. There is some very small indication for the utilization of giving Methergin IV very, very slowly, like over a minute or two, only in really severe life-threatening hemorrhage. And the literature is kind of contradictory about that. Chestnut actually says you can give it very, very slow IV push in those severe cases. CMQCC, which is the California Maternal Quality Collaborative, actually says that it cannot be given IV. Side effects, of course, are hypertension, arterial constriction, as well as patients can get nauseous and vomit after a dose of Methergin. It has a longer duration of action, and it can be repeated one time after an hour. Moving on to Hemabate. Hemabate is, again, an effective uterotonic agent. It increases intracellular calcium and helps to enhance other uterotonics. It can be given IM, or it can be injected directly into the uterine muscle. When we give an IM, we give 0.25 milligrams. It is contraindicated in patients who have asthma or reactive airway disease, as it can cause bronchospasm. It can also cause pulmonary hypertension, resulting in hypoxemia. And we need to use it cautiously in patients with hypertension, but it is a better option for the hypertensive patient than Methergin is. So we avoid Methergin in patients with severe hypertension. We avoid Hemabate in patients with asthma or reactive airway disease. Side effects of Hemabate is fever, chills, nausea, vomiting, and like I said, bronchoconstriction. Hemabate can be repeated every 15 minutes up to 2 milligrams. So oftentimes we say Hemabate times 8. So you can give it 8 times, once every 15 minutes, up to 2 milligrams. Lastly, we have Cytotec, and Cytotec is a prostaglandin analog that is generally used for cervical ripening and induction of labor, but it can also be utilized as a uterotonic in cases of uterine atony. And Cytotec is given as in a few different routes. It can be given per rectum, sublingual, or PO. There are no contraindications to Cytotec. But there are some side effects: fever, chills, nausea, vomiting, diarrhea, as well as this is really an off-label use for this drug. But again, it's kind of one of those last-ditch effort drugs when we've been using all the other uterotonics. What are we doing to try to get that uterus to constrict? Oftentimes, Cytotec will be used as well. So the next reason for postpartum hemorrhage is something called retained placenta. And retained placenta kind of goes hand in hand with uterine atony. What does retained placenta mean? Well, basically it's failure to deliver the placenta within 30 minutes of infant delivery. And it doesn't necessarily mean that the entire placenta hasn't been delivered. So oftentimes fetus is delivered, placenta is delivered, but not the entire placenta. There may be small pieces or fragments of the placenta that are left in utero. If the uterus doesn't empty completely after delivery, it will not contract. And so basically you have a uterine atony situation. So those arteries of the decidua basalis will continue to bleed. This happens in about 1 to 5% of deliveries. And like I said, retained placenta is one of the causes of uterine atony. So what are the risk factors? History of retained placenta from a previous pregnancy, preterm delivery, oxytocin use during labor, preeclampsia, and nulliparity. It's usually diagnosed via ultrasound or manual exam, or sometimes it's a bit of a diagnosis of exclusion, like we don't know why the uterus won't contract, it's very atonic, we're not sure why. Sometimes they decide they're going to go in and explore for retained placenta, thinking that could be the reason why there's uterine atony. The treatment is, again, manual exploration, or sometimes the patients are sent to the OR for evacuation and curettage to make sure that the uterus is adequately cleaned out. So what are the anesthetic implications for this? Well, if the uterus needs to be explored, then we need to get the patient comfortable. So we need to give analgesia, sometimes uterine relaxation. So you have a few options. If the patient has an indwelling epidural, the epidural could be redosed. You could give a spinal, or you could give general anesthesia. Additionally, you could give just IV sedation. The volatile agents, of course, are going to relax the uterus for you. If you decide, if general anesthesia isn't really a great option for this patient, because obviously these patients aren't great candidates for general anesthesia because they're high risk for gastric aspiration, high risk for being a difficult airway, maybe opting for IV sedation is a better option, and nitroglycerin can be used as a uterine relaxant. So you really have to weigh the pros and cons when you're getting called to a situation for retained placenta where uterine exploration needs to be done. So what options do you have? You need to think about the pros and cons. Uterine inversion, another reason for postpartum hemorrhage. This is when part or all of the uterus basically turns inside out. It occurs in about 1 in 5 to 10,000 pregnancies. The risk factors are uterine atony, inappropriate fundal pressure when the baby is being delivered, umbilical cord traction, so traction on the umbilical cord trying to get that placenta to release causes too much traction on that uterus and actually can cause it to invert. Uterine abnormalities or anomalies, as well as placenta accreta puts patients at higher risk for uterine inversion. So what are the anesthetic considerations? Well, we get called for a uterine inversion situation. First thing we need to do is hold the uterotonics. and we need to treat hemorrhage that's happening as indicated. So does the patient have IV access? Do they need blood? Do they need warm fluids? Give oxygen? General anesthesia may be necessary so that we can relax the uterus, or IV nitroglycerin to relax the uterus. After the uterus is successfully reduced, then we'll restart the uterotonics and, of course, shut off the halogenated agents if we are giving general anesthesia. Next reason or cause of postpartum hemorrhage is something called placenta accreta. So placenta accreta, if you remember from nursing school, is when the placenta abnormally embeds itself into the uterine wall. In a normal pregnancy, the placenta attaches to kind of this temporary layer of the uterus, and it's shed on delivery, and that's when the placenta releases itself from the uterine wall. But in the situation of placenta accreta, the uterus embeds much deeper into the uterine wall. And placenta accreta is further kind of categorized as placenta accreta, placenta increta, and placenta percreta. And those different terms actually indicate how deep the placenta is embedded into the wall of the uterus. So with accreta, it attaches deeply into the uterine wall. With increta, it actually attaches into the uterine muscle or into the myometrium. And placenta percreta actually embeds completely through the uterine wall, and sometimes it actually can go completely through the wall of the uterus and into other organs of the body. So it can actually attach to the bladder, which, as you can imagine, would be a really severe situation. So anesthetic management. Well, obviously you need to be ready for massive hemorrhage. You want to make sure you have large bore IVs, type and cross match, potentially cell saver. It used to be thought that you could only use cell saver after the delivery of the fetus and the placenta because you wanted to avoid amniotic fluid, transfusing amniotic fluid. But cell saver blood is so thoroughly filtered now that there's really no risk for that anymore. Of course, this patient is going to go to C-section, and oftentimes, especially if it's an increta or percreta, then the patient is going to have an obstetric hysterectomy after delivery of the baby. General anesthesia or neuraxial anesthesia is acceptable. However, it's important to recognize that surgery could be prolonged. And if there's an active hemorrhage, general anesthesia is actually preferred. So these patients are generally diagnosed in the prenatal period, so it's known that the patient has a placenta accreta and they are scheduled for a cesarean section. Lastly, another cause for postpartum hemorrhage is genital trauma, and this can be a result of lacerations and or hematomas of the perineum, vagina, or cervix. The blood loss is usually venous in origin and not generally severe, but sometimes we are called because the obstetrician needs to do some exploration as well as repair. And so we are oftentimes called to either redose an epidural if they have an epidural, or maybe give some IV sedation while they do the repair. And once in a great while, there's an extensive repair that's required that may necessitate either placing a spinal if they don't already have an epidural, or general anesthesia. So again, weighing the risks versus benefits of your types of anesthesia in that specific patient. Next, I just wanted to introduce you to some of the more invasive surgical treatment options for some of these situations in order to help be kind of proactive in the management of postpartum hemorrhage. So there's something called an intrauterine balloon tamponade. This is just a device that's inserted into the uterus, and as it expands, it puts pressure on the walls of the uterus to kind of tamponade and stop that bleeding, if you will. You may also hear this balloon called you may also hear this balloon be called a Bakri balloon. That's B-A-K-R-I balloon. That's the Cook company's version of it. Additionally, there is a technique that surgeons can use or obstetricians can use that are to place uterine compression sutures that actually kind of compress the uterus with those sutures. If patients are stable during a postpartum hemorrhage, they could be sent to have an angiographic arterial embolization done. I've personally never clinically seen this done because generally when we recognize patients are bleeding, they wouldn't be stable enough to go sit for this kind of procedure. Another option or surgical intervention for postpartum hemorrhage is uterine artery ligation. And you can see a picture there where the uterine artery is actually ligated in 2 different places, thereby causing a decrease in bleeding. Lastly, and kind of as a last result to postpartum hemorrhage, is something called a peripartum hysterectomy. And this is the definitive treatment for postpartum hemorrhage. And we only do this when patients are completely unresponsive to any other medical or surgically invasive therapies. The most common causes of peripartum hysterectomy is uterine atony and placenta accreta. If you remember from the GYN lectures, there are 3 types of hysterectomies: partial, total, and radical. Oftentimes, again, pros, cons, benefits, risks are weighed. If a patient's known in prenatal period that they have a placenta accreta, the obstetrician is going to talk to them about the potential for a hysterectomy and the need for a hysterectomy, and they're going to do what they can to preserve the ovaries if possible, but sometimes they just have to do whatever they whatever they can get to, and so a total hysterectomy is oftentimes performed. One other thing that is sometimes seen as sort of not a treatment method, but a way to kind of slow postpartum bleeding down and so they can figure out or treat the cause is just some manual compression of the aorta. And again, that's not going to treat anything. It's just going to slow that bleeding in the uterus down so that maybe some blood can be given or coag factors can be given to help kind of try to treat the cause of the bleeding. So that's really all I have to say about causes of obstetric hemorrhage. Part 2 is going to be about treatment of obstetric hemorrhage, and we will focus on how to best manage hemorrhage by recognizing what the cause is and try to be very specific about the way we treat. And